So moving on to the sedation dose of ketamine. Again, in the pre-hospital setting, we're going to be using this for behavioral emergencies, specifically an excited delirium patient. The best thing about ketamine for these patients is the faster onset than Haldol. In a recent study, ketamine injected IM took an average of 5 minutes for complete sedation versus Haldol's 17 minutes. A significant minority of the patients in this study did have significant side effects such as respiratory depression or vomiting without the ability to protect the airway. While these side effects may seem alarming, in the pre-hospital setting, sedation doses are used with extremely combative patients that are at immediate risk to themselves or others. EMS providers will have the training and equipment to deal with side effects such as managing the airway. In the clinical setting, a sedation dose may be used for short procedures, such as reducing fractures or suturing. If you have a setting in the pre-hospital sense where you feel it is appropriate to procedurally sedate someone, always contact medical control. This might be for a shoulder reduction or for pacing a patient. And again, anytime that you have used a sedation dose with ketamine, you must use end-tidal CO2 monitoring. So what does a sedated patient look like? They're going to be in a trance-like state with their eyes open, staring off into the distance. They may have normal or slightly increased muscle tone. Their airway reflexes usually are maintained, such as the ability to cough and swallow. Again, their blood pressure and pulse may be elevated, and at sedation doses, you will see nystagmus. When would we use the sedation dose in the pre-hospital setting? We've covered this a little bit already, but this is an important distinction to make. Our most common scenario would be an excited delirium patient, which is a combative patient who's an immediate threat to themselves or others. The goal with this is to reduce the patient's combativeness and address the scene safety. After the patient is sedated, it is appropriate to consult medical control to discuss prolonged sedation, appropriate doses, transport, and so forth. If ketamine alone is ineffective at controlling the patient, it is acceptable to switch to IM Versed. Note that these medications are not being given simultaneously. Also, the provider must be able to articulate that the patient continued to pose an immediate threat. And as we already discussed, always be prepared to immediately address airway management in the patient if the patient has a drastic reaction to the medication. There may be other situations where procedural sedation dose may be appropriate, such as shoulder reduction if CMS is compromised, or pacing or cardioversion of a patient. In these cases, medical control should always be contacted before procedural sedation. Do not co-dose ketamine and Versed for procedural sedation without specific approval from medical control. Legally, this looks like a whole lot like RSI. With a lot of these situations, such as shoulder reduction or pacing or cardioversion, you'll probably be able to achieve the desired effect at the dissociative dose. Ketamine is a pregnancy Class C drug, which means that the risk has not been established or ruled out. Adverse reactions have been observed in animal studies, more commonly seen with longer duration use. We do know that ketamine can cross the placental barrier and is detected in fetal tissue. Although the FDA does not have official recommendations, ketamine is not recommended for use in pregnancy by the manufacturer. Pediatric use. Ketamine is often the preferred medication in a clinical setting in pediatrics for short duration procedures, such as resetting fractures or suturing. It provides a sedated patient who does not respond to pain without general anesthesia and is relatively short-acting. Ketamine is considered safe in patients older than 3 years. From 3 months to 3 years, there have been studies showing that prolonged use, such as use over multiple surgeries or procedures over 3 hours, may negatively affect brain development. The FDA has approved ketamine for use in this age bracket with the warning against prolonged use. Pre-hospital settings are unlikely to significantly affect this, as usage will generally be less than this critical period of time, and you will contact medical control for any repeat doses. Ketamine is contraindicated for patients under 3 months of age. Some considerations with ketamine in Yosemite. Park medics must contact medical control prior to any administration of ketamine. Paramedics can administer initial doses without medical control contact in behavioral emergencies over 10 years of age and administering for the pain management dose or the subdissociative dose for patients above 3 months of age. Paramedics must call for repeat doses and must call if administering a sedation dose for reasons other than a behavioral emergency. Bottom line is park medics must always call. Paramedics must call for repeat doses in unusual circumstances. If you are in communication failure, you can administer ketamine based on the doses listed in the protocol and based on your best faith of what the medical director would advise. Continue to attempt to contact medical control throughout your call. As ketamine is distributed to ambulances and providers, a dosing chart will be given out with it. I'll also include a copy of this chart as a Word document in the email sending this training to providers. Given that ketamine is dosed based on patient's weight and that there are multiple dosing levels to consider, medication errors with ketamine are a real concern, and math in public is no one's strong suit. It's best to use this chart and have someone check your calculations before any administration to avoid errors. With this chart, the most important thing to note is the doses are calculated in volume, or milliliters, to take one more step out of the calculation for proper administration. However, you must note the actual dose in milligrams for documentation and handoff reports. Note that dissociative doses up to 0.5 milligrams per kilogram are permitted under Yosemite's protocols. To avoid an overly cluttered chart, we only listed 0.1 to 0.3 milligrams per kilogram doses. Providers can use simple addition to find the higher doses. Additionally, sedation doses are only approved in the protocol for 1 to 2 milligrams per kilogram. However, if ketamine is being administered to a patient with excited delirium and the initial dose is ineffective, medical control may approve a higher sedation dose, which is why 3 milligrams per kilogram is included in the chart. Drawing up ketamine. Using the appropriate syringe for the dose is important. If you are administering an analgesic dose, use a 1 milliliter or TB syringe. If you are administering a sedation dose, use a 3 or 5 milliliter syringe. During the hands-on portion of the ketamine sign-off process, you will be required to appropriately draw up 2 different doses of ketamine. These will not be full scenarios. The skill being tested is simply your ability to determine the correct dose based on weight and medical control orders, and to physically draw up the correct dose. A couple other considerations for the administration of ketamine. There's support for the idea that when providers coach the patient during administration to think of a happy place, that the patient will have a better experience while on ketamine and have fewer side effects withdrawing from it. If you're administering ketamine intranasally, the MAD device, or mucosal atomizing device, has a 0.1 milliliter dead space amount. Draw up an extra 0.1 milliliters of the drug to account for this space. This is true for any medication that you are administering intranasally. Since we're talking about ketamine, we'll touch on the recreational use. It is a popular recreational drug that is structurally similar to PCP, and street names include Special K, Kit Kat, and Cat Valium. It's found in powdered forms, which is either ingested, snorted, or rectally administered, or liquid forms, which is administered IV or IM. Those taking ketamine in higher doses want a mellow feeling, be pain-free, and experience mild visual hallucinations. This is referred to as going to K-land. Going to K-hole, on the other hand, is a higher or sedative dose of ketamine, and individuals may lose the ability to move, have vivid hallucinations, short-term memory loss, and experience an out-of-body experience. The paralysis and short-term memory loss are the main reasons why ketamine is seen as a date rape drug. EMS generally does not contact overdoses for ketamine, as the side effects generally do not present in life-threatening ways. However, if we are called to an overdose, we'll probably see either respiratory depression, violence or terrors related to the hallucinations, seizures, paralysis, or extreme sedation. As we have no reversal agent for ketamine, treat the symptoms, such as managing ventilations and airways, and if needed, consider Versed for seizures.